like the karaoke mic on this. All right. Okay. Thank you so much for having me here today. And hopefully I can give you some answers about CAR T. And it's interesting that Greg said you're seeing one end of it, which you just heard about smoldering and MGUS, and this is the other end of it. But I'm going to argue that maybe it shouldn't be the end, but maybe earlier, which would be great. So I'm Nina Shah. I'm from the University of California, San Francisco, which is 3 time zones away, but that is good for me because I like getting up early. Okay, so everybody knows that triple refractory multiple myeloma, refractory to our traditional drugs, we may have heard bortezomib or Velcade, lenalidomide or Revlimid, plus daratumumab or isatuximab, those patients do really poorly. And this is illustrated by this mammoth analysis you can see here, where patients who were either triple refractory, non-triple refractory, or penta really do poorly, both from progression-free survival and overall survival. And this means that we have an unmet need. And I really applaud many of you and all the patients out there who are listening, who have participated in clinical trials, for us to understand this better. So, then we talk about the unexpected stars of myeloma therapy. I promise you 6 years ago, I would not have been saying this, but it's true. Immunotherapy has completely changed myeloma. And I say, it's like, it's like Travis Barker and Pete Davidson, like, were they really going to get the Kardashians? Who thought it? Right? But they got them. And it's true that it's not just lymphoma that has immunotherapy. We have it too. And it's actually becoming a huge player in our myeloma our toolbox. So we have antibody drug conjugates, bispecific T cell engagers, and of course, my favorite, CAR T cell therapy, which I'm going to talk about today. So how does CAR T differ from other therapies? Now, I will be showing you a lot of data slides. Don't worry about the data. This is just so you understand how we as the physicians come up and researchers come up with our ideas of how to treat patients. But what does it mean for you? So this is important for anybody who's considering going to CAR T therapy, that there are 2 parts of it. There's what happens to the patient and what happens to the cells. And that it has this sort of overlapping aspect. First, the patient is identified, you'll be identified. There's all this testing, very similar to transplant, the echo, et cetera. You have to stop your chemotherapy 2 weeks before what we call apheresis. So many of you have had a transplant and you know that you undergo this collection from your blood. This is actually just a 1-day process, and it doesn't require the white blood cell stimulating drug, the GCSF or Neupogen, as you may know it. Once that happens, and even getting that slot is a whole other thing, but once you get there and once that happens, those cells get shipped off somewhere, maybe New Jersey or wherever, and you wait for a couple of weeks. And what happens to those cells is that those cells get engineered. The cells get incubated with this lentivirus, this alternate virus that allows for the genetic code of this CAR, this chimeric antigen receptor, to be integrated into the DNA. And what does that mean for you as a patient? That when these cells come back to you, they now have this nice protein on the outside of their cells that will recognize your myeloma cells. And we know that T cells are a very active way for us to kill viruses. And now these become an active way for them to kill your myeloma. So while you're waiting there, back at your home base, and these T cells are sitting in New Jersey being engineered, what happens? So even though it only takes 2 weeks to actually engineer them and grow them, there's a lot of quality control, right? You don't want these cells to be growing out of proportion to what they should. You don't want them to be sort of taking off and being, cancerous by themselves because they've had genetic engineering. You also don't want them to have infection, right? These are living drugs that are growing, and anything that's living and growing can have an infection. All these things have to be cleared before these cells can come back to you. And that takes a couple of weeks. It can take as long as 4. I've even heard now thinking like 6 weeks. And so, and it's hard because you, the physicians and the patient are like, well, what am I going to do then? And we do things called bridging chemotherapy to help you to control your disease during that time if necessary. So that's what happens. And then the cells come back. We give everybody lymphodepleting chemotherapy, which is 3 days, of fludarabine and cyclophosphamide. Many of you have had cyclophosphamide or Cytoxine. These 2 drugs combine and make room for these T cells that are a little bit foreign. They're yours, but they've been engineered. Make room for these T cells to come in and do their work. 2 days later, you get the T cells, and then we watch and wait what happens. We'll talk about that. Okay, I'm going to fly through a lot of this because I want to focus on what's important to you guys as patients. This is how the process goes, that part right there. You can see that it's different. Now, why is this important? Okay, so I'm telling you, 6 years ago, we didn't know any of this. 2017, remember what that was? That was a pandemic. All these things happened in 2017, and I actually think this world was totally different. But the other thing that happened in 2017 is we first heard about BCMA CAR T cell therapy for multiple myeloma, that it made a splash. And in this very small phase 1 presentation, no one really knew about it. It was going to happen, wasn't anticipated. Huge splash, 100% overall response rate, unheard of in patient with 7-8 lines of therapy. So this is really the data that started the whole force to get CAR T cell therapy developed and approved. This is the pivotal KARMA study, the KARMA-1 study that was for BB2121. That's a BCMA-directed CAR T cell therapy like we talked about. This was the phase 2 study that got this ultimately approved. Patients with relapsed refractory myeloma, at least 3 lines of therapy before. We'll talk about what that means. But in this study, the patient's median had 6 prior lines. That's a lot of lines for you guys to know what all these different therapies. It's a lot of different chemotherapies people had gotten. And eventually on the right-hand side, you can see that 73% of patients responded. Really unprecedented data. I want to remind you that in myeloma, we generally get FDA approval for around 30% response rate. So this is really good. And furthermore, there were several doses picked here, and the dose, that's the top dose, that 450 million dose in the third bar, that ended up being the highest overall response rate of 82%. That's sort of how we recommend that these these cells get engineered and dosed. Cytokine release syndrome, we'll talk about it later, pretty well controlled. The median progression-free survival here, that means how long did people last before something happened, was 8.8 months. But actually, if you look at the 450 dose, that's on the left-hand side, that top curve, the patients who got this T-cell therapy at that dose had a median, means 50% did better and 50% did worse, of 12 months before anything happened to them. Now, that doesn't seem like a long time in a way, but if you think about it, this is one-time therapy and then nothing else. And that's, I think, the way that CAR T differs from what you would get really as a regular drug. A lot of you know, you go to cycles and cycles of chemo. This is a one-time treatment, something that I really like. Oh, sorry, I wanted to point out, actually, hold on before I get there. But on the right-hand side, you can see who did the best. The people that had the top curve are the people who got into a complete response or stringent complete response. And I want you to keep that in mind, because we're trying to figure out who those patients are, because those are the patients we want to give this very complicated and expensive therapy to, because they have the most potential to benefit. Okay, so that's ide-cel, but there's also cilta-cel. Anybody who knows how Kim Kardashian got famous, she was actually the friend of Paris Hilton. And at first, Paris Hilton was super, super famous, but then this friend showed up, and next thing you know, boom, she's got an empire. So I think that's possibly what's going to happen to cilta-cel based on this data. This is the CARTITUDE data presented by my awesome best boss in the world, Tom Martin, this past year at ASH. This was the updated data. This is also a BCMA-directed CAR T-cell therapy, a little bit different because the outside surface, the part that binds to the myeloma protein, is binding 2 parts of it, and that might explain some differences that we see between this and some other CAR T-cell therapies. This is what you have to know. You got patients with 6 prior lines of therapy. These people had a 98% response rate. Unheard of. That's the kind of data you see when you have newly diagnosed myeloma, right? Almost everybody responded. And not only that, the depth of response, meaning how much did they clear that M protein in those light chains? 95% of them had a VGPR, a very good partial response or better. That means 95% of patients cleared at least 90% of their disease, which is great because we know that deeper responses in myeloma usually equate to longer follow-up, longer responses. Now here, they did have, most patients actually did have CRS or cytokine release syndrome, but it actually was generally well controlled. There's also some alternate neurotoxicities, and we don't have too much time to go into that, but there are things that we can maybe control with disease burden. What I want to show here is that we don't actually have the true median PFS as of yet. Maybe we will this year in a few weeks when we have our next conference in June, but at the 2-year mark, over half of the people, so 60% of patients, were still quote unquote in remission or had maintained their response. So this is probably going to beat 24 months, which would be great. Again, one-time therapy. And for 24 months, patients don't have to come back and get chemo or anything else. There are some other side effects, but I think this is something that really can give people back their lives. And the reason I'm such a huge proponent of CAR T-cell therapy, if we can get it to last, is that that's the thing. It's like myeloma is a marathon. If I could just prevent the patients from having to come back to the infusion center every week or every month, we would have done something good for the patients. Of course, we always talk about MRD negativity. If I had a dime for every time someone asked me about MRD, I certainly wouldn't need to work as hard. But people who get into MRD negativity, they do better. Everybody knows that. Again, deeper responses, people do better. So if you can eradicate the most disease you possibly can, which seems like some of this CAR T therapy can do, you have a better chance of having a longer duration response. So how does CAR T differ from other therapies? this box is how it differs, right? This is the whole process that I explained before, that you have, it's a living drug. You give your cells, those get engineered, and then those get back. So it's like more of an intense upfront payment of logistics and therapy in this sort of 6 to 8 week period that you're really kind of tied to the specialty center, very similar to transplant. But look, there's nothing after the red box. That's the other way it differs, right? That means that if you're done and you really have a good outcome, and I've had patients who have this, not all, but some do, it's really remarkable that people get back to their lives and go see their grandkids graduate and all these other things that we really hope people can see as myeloma patients. This is what I think is one of the most important things. And this is the ida-cell data, but this is also true for cilta-cel. This is a quality of life measure. This is the mean change from baseline and scores. Basically, fatigue and pain, those are bad symptoms. You don't want those, right? You can see here for both of these symptoms that both of these went below a threshold. The blue dotted line is an important threshold we define, and both of those symptoms went lower from months 1 all the way out through months 9, 12, and 15 after one treatment. So the bad symptoms are less and the good symptoms are better. Physical functioning, health-related quality of life, those are better and persistent as such. So people are certainly not having worse quality of life for this one-time treatment. And then there's I think these secondary subscales. We just published this in one of our articles, the QLQ-C30 secondary subscales. This is what I think makes patients people, not just patients, right? The things that make you a complicated person, role functioning, emotional functioning, social functioning, all of these things also were elevated beyond a certain threshold and came and persisted throughout, even though there were several months out from the initial treatment. So I think that's a really big way that CAR T-cell therapies differ from other therapies. And I think this quality of life data is going to be huge when we try to compare things one from another. So how do we evolve knowledge to limit side effects? Now, okay, there's a practical aspects of giving CAR T-cell therapy. There's what the FDA labels, right? Like the FDA says that you have to have at least 4 prior lines of therapy. And I can't even get into all that because it's difficult to get there, and you can't have significant comorbidities. What does that mean? That means that you have to be generally healthy. Now there's all these scales you can use. I have my own test. It's called the Target test. I always ask the patient, if I asked you to go to Target and pick up a few things, could you do it? And they're always like, yeah, totally. And their spouse is like, no, I don't think they can do it. And because going to Target is very stressful. And so if you can do that, I think you can definitely get CAR T therapy, but you just have to be generally healthy. I think it's actually easier to do than a melphalan transplant. And I love transplants. So for me to say that is a big deal. There are logistics you have to think about. You're probably going to have cytokine release syndrome. We'll talk about that. That's CRS. The cell infusion is inpatient. You have to go to a cell, or it could be inpatient or outpatient, but you really have to be at a specialty center. And then afterwards, there's this co-monitoring between you, the specialty center, and then your local doc. And that has to be a really, really tight conversation. So you know that you can go back home and still be monitored the way you need to be. Okay, cytokine release syndrome is like, I call it the graft versus host disease of immunotherapy, because basically it can affect any organ. It's basically the worst flu you ever had, a lot of fever. It's marked by fever, but can also have other vital signs like high blood pressure affected. And we think that maybe the disease burden can be related, although not always. We have a drug called tocilizumab. So once somebody has this fever after CAR T cell therapy, I'll give Tylenol, but I'm actually very quick. I'm quick to give the toci. I always call it hashtag no toci shame. Because why? Because it works. This tocilizumab is an antibody against the IL-6 receptor, and it's very effective at sort of turning off the syndrome of CRS. And why? Because we don't want people to end up in the ICU, right? The whole point is to do no harm. We want to do good. So we give that. If necessary, we give steroids, and in rare circumstances, we have to give additional chemo to turn those cells off. Why do I like to give toci? It's a complicated table, but we just published this data last year. Basically, we looked at all of our CAR T cell therapy infusions at UCSF, and for people who got early toci, meaning within 12 hours of their first fever, versus late toci, like we let them fever and let them have more time and then gave them toci, no differences. It doesn't change the progression-free survival, the efficacy, any of that. It doesn't change anything. And theoretically, it could shorten hospital stay, which is a big deal. So I actually feel like if patients have that second fever, I give the tocilizumab right away. And the next day they're like, oh, great, I feel much better. And honestly, who wants to get paged in the middle of the night, right? So that also helps me. Okay, what are other symptoms you can have? You may have heard neurotoxicity. We call it ICANS because we have to make an acronym for everything. Immune cell effector associated, or immune cell associated neurotoxicity syndrome. Anyway, basically, people become confused. And I say, honestly, it's like you're drunk. And the reason for that is that there's some sort of inflammation being caused by the systemic inflammation. And there's a lot of things that can manifest it. If you let it go for too long, people can have seizures, go to the ICU. But if you recognize it, it's important to see and assess. Remember, all these other things are going on in the hospital too, right? People are staying overnight. A lot of patients are older. They're getting fludarabine. They have fever. There's a lot of reasons why people may be a little off. So we want to keep a good eye on how to make sure we're checking people from time to time to time. And to do that, we have this ICE tool, which has been developed through the ASTCT, that's our Cell Therapy Society, and agreed upon. And we ask these kind of silly questions, but they're good. And they give you a 10-point score. And they really focus on things like your ability to concentrate, recall, and write. And you can see, we do it twice a day. It's like just a stand, it's like our other vital sign now for our nurses to administer. And you can see how the handwriting can change during the time that person may have neurotoxicity. I'm telling you, the first person to ever notice that the patient has neurotoxicity, the caregiver, right? Because that person's in the room with them a lot. The second person to notice is the patient's bedside nurse, because that person knows. So as soon as these ICE scores start to drop, I actually jump on it right away, because I don't want the patient to get a seizure. I don't want the patient to go to the ICU. And we know that giving steroids in the lymphoma data really hasn't caused any bad effects as far as the efficacy goes. So how do I manage this? I put all my patients on seizure prophylaxis. So you may be getting an extra drug, something called Keppra or something like that, to prevent seizures only in the time that you're going to get the CAR T cell therapy. I usually start a little bit before the cells get infused. And then if we need to, we can give steroids, or eventually we can give chemotherapy if necessary to turn off the T cells. But really, I think a dose of steroids, a couple of doses, can really mitigate this very nicely. Other toxicities, this is what you will experience once you leave. And these are the low blood counts we call cytopenias. We can give things like Neupogen or GCSF to help. A lot of times people leave the center, 30 days out, and they do need some spot dosing here and there of Neupogen or GCSF. And so their local provider can provide this. So that's why it's so important for us to communicate with you and for you to communicate with us, and then us for the local provider. It has to be a matrix to make sure you have a smooth transition, similar to transplant. There's this thing called MAS, or macrophage activation like syndrome, that I don't want to get into the biology of it, but basically it's like a really big systemic inflammatory syndrome. In order to treat that, we actually have this IL-1 antagonist called anakinra. So you may be hearing about that. Really pretty rare. It doesn't happen too much, but when it does, we now know how to manage it a little better. And immunosuppression. This is huge. A lot of patients will say, oh my goodness, my IgG level is so low. Yeah, that's actually a good thing. That means we did a good job killing all those plasma cells, but it's a bad thing because you're now susceptible to other infections. So we often will give IVIG as a supplemental supportive care, especially if the immunoglobulin drops below 400. That's our practice based on the clinical trials, but that's not a hard and fast rule. We do give everybody their acyclovir. We check the CD4 counts. You may be getting Bactrim or Septra, those drugs to prevent different kinds of pneumonia. These are all part of the way to sort of support you as we give a very effective therapy that might be also suppressing your immune system. Okay. So CAR T cells, right now, what are we going to do? So I equate this to like bringing home a new baby, and you're like, oh, okay, now what? Because, you have this big thing, all this excitement. Now it's just you and your spouse and this newborn. So what? Okay. So now the label now says 4 lines of therapy. When, I was actually involved in all the FDA stuff to get this through, and they really want to make sure that you're going to get this because you need it. And so I thought, okay, 4 lines, no problem. But now I have patients. I'm like, man, how am I going to get them through 4 lines? Because they get this therapy, and they get transplant, and they get Dara, and they get carfilzomib, and what happens then? And anybody knows I'm a millennial, means like I don't use old drugs. So all the millennials, we all use new things. So we might use Ola's favorite KRD, or Dara KRD, or Dara VRD, because of the Griffin trial. And then what are you going to do for lines 2, 3, and 4? I think logistical challenges like vein to vein time, this is always a problem. Trying to make sure that when the cells go out for shipping and when they come back in that time, that it's not too long, so that your disease doesn't blow up. And then we want to pick the right patients to optimize outcome. I'm going to talk about that real quickly. And also, how do we compare this to other immunotherapies that are coming down? So when's the right time for CAR T? We try to look at this. So we just looked at this, and this is presented this past year at our conference. What predicts for who's going to get that complete response? I'm not going to go into all the statistics, but the short of it is, look at the red arrow, that if you have IgG heavy chain disease, or a lot of serum BCMA, or an elevated coagulation factor, that you're less likely to get a complete response. What does this mean in normal speak? This means if your disease is really bad, you're less likely to respond. Well, of course, we all know that, right? But this means that we have to pick patients who aren't at the end, that aren't having their disease uncontrolled and blowing up and unable to be salvaged. We have to pick people who are just seeing the disease start to perk up. Those are the people that we should be taking, I think, to CAR T therapy. At the bottom, this vector copy number, the higher it is, the better you're able to do. That means, to me, T cell fitness. So we shouldn't be taking these patients with so many lines of therapy. We want to make sure that their T cells are healthy enough in order to actually produce healthy T cells. Very similar data has been seen with the cilta-cel product as well. Okay, so what does this mean? I think this slide, this is just for ide-cel, but this is something that I think we're looking at for cilta-cel as well. These are just the trials that are going on. We have them in the late phase. We should pull them earlier when patients are less aggressively, have less aggressive disease, have more time to plan, and their T cells are better. That's my story. I'm sticking to it. I think it's going to become second line by 2023. We have this ongoing BMT-CTN trial looking at patients who may not have gotten to VGPR or CR after maintenance, after transplant, consolidating them with CAR T. This is open at a center near you. And then finally, thinking how we're going to think about CAR T versus bispecifics and antibody drug conjugates. They're all good. There's enough myeloma to go around, but you have to decide what's right for you and what the logistics will afford. One-time therapy is great, but you can't always get it. And if not, I think the approval of bispecific therapies is going to be very, very important as an available off-the-shelf option. A lot of CAR T cells coming down the line, not just BCMA, but also GPRC5D at the bottom there. And we're looking forward to new data from our conferences, and really, really, because all of you guys participated in clinical trials, so important. We couldn't be standing here without that. So in conclusion, CAR T cell therapy for myeloma yields impressive overall response rate, survival data, one-time treatment. I think that's the best thing about it. No cures yet. My boss always says we have plateau envy, meaning the curve isn't plateaued. And we have to figure out how to optimize this, both where the patient is as far as their diseases and where they've been as far as their previous treatments, and consider cost, quality of life, accessibility. Early referral is key. Clinical trials are a must for anybody who loves himself some Ted Lasso. Clinical trials are life. I don't know who's seen Ted Lasso, but it's true. Danny would say the same thing. And with that, I want to say thank you. This is our team at UCSF. We're very compliant. And we finally resurrected our Cinco de Myeloma party that we have every year. Finally back in circle on the bottom left. They're so excited people were able to actually have it. Oh, and I think that's the end of the talk.